everyone. I welcome you all for today's webinar on Clinical Update in Oncology 2024. With immense pleasure, I would like to invite Dr. Major General B.N. Kapoor sir. He is the Director of Medical Oncology at Yashoda Hospital, Ghaziabad, for the welcome and introductory note. It's over to you, sir.
Yeah, thanks a lot. It's my proud privilege to be the part of this clinical update in oncology 2024. And I believe this must be the last update in oncology of this year. It's my proud privilege, and I invite all the speakers and the panelists for this today evening webinar. Lot of advances have taken place in oncology, and especially in non-small cell lung carcinoma. Targeted therapy has made a great difference in the management of non-small cell lung cancer. And all this has happened after we have come to know the diagnosis and the molecular markers which can be targeted in non-small cell lung cancer. To deliberate on the molecular markers or the biological markers, I do invite Dr. Anuradha Chogaya from Mumbai. She will be deliberating on emerging biomarkers for non-small cell lung cancer. Dr. Anuradha, please. Is Dr. Anuradha there?
Yes, sir. She is there.
Yeah. Can she deliberate on it? Hello?
Yes, sir. She's here, sir. She'll be speaking on it, sir. Thank you, sir.
Okay. Yeah.
किया है मैंने अनम्यूट पर मुझे can you hear my voice?
Yeah, Anuradha, you are audible.
Can you hear me?
Yes,
Yeah,
ma'am.
Dr.
Yes,
Anuradha,
ma'am.
you are audible.
Yeah.
You can start. Yeah.
Okay, give me a second. Yeah. I'm not able to share the screen. Let me see. Yeah, now I can do it. Yeah.
Yeah, it is visible now.
Yeah, 1 second. Yes. Yeah. First of all, let me thank the organizing committee for giving me this opportunity. So today I'm going to speak upon the emerging biomarkers in NSCLC and the clinical update in oncology of 2024. As you all know that the evolution in drug development and rational therapeutics that target the specific oncogenic dependencies has led to the improvement in overall survival rate in the lung cancer. So the field of biomarker testing in NSCLC is expanding rapidly since the discovery of EGFR mutations in lung cancer. All of you are well aware of that. And the expansion has been driven by extra advancement in sequencing technology like NGS. So there is no substitution for NGS. Like we have to looking at the bigger panel, we have to have the NGS to do it. So here you can see that. Sorry. The molecular characterization of NSCLC has revealed a large number of oncogenic alterations, as you can have the look at the NTRK, red fusion, BRAF, HER2, exon 20 insertion, which has become very important because of the treatment targeted therapy which has come up. So also you get to see the ROS1, MET exon 14 skipping, ALK rearrangement. So these are all the important biomarkers which have emerged in the clinic. As per the which can be performed in the multiplex platforms like NGS for molecular testing and are preferably by NCCN and ESMO guidelines. So here you can see what are the factors you need to keep in mind when you are performing the NGS test, when you're advising the NGS test in lung cancer. As you all know, the EGFR test began way back in 2013, and this was our first paper where we documented the 23% of overall frequency rate in India in Indian cancer patients. And latest, I would like to show it over here, the real world evidence of EGFR targeted therapy, which was published in last year in Journal of Thoracic Oncology, where a decade data, that is around 9,000 plus cases of EGFR was published, and almost it showed the similar overall frequency rate from 25% to 28%. And the highlight was of all was that the EGFR T790M and other compound mutations were seen basically in the to develop better therapeutic regimen for co-occurring in the baseline. So new data has emerged to warrant changing the original recommendations. So old key questions and new key questions. Let us see what other genes previously not addressed should be tested in lung adenocarcinoma. Is immunohistochemistry reliable for screening for ALK translocations in patients who are undergoing treatment with TKI inhibitors? What are the types and rates of secondary resistance? And what are the clinical performance characteristics of circulating DNA CTC in plasma when used for diagnosis of primary lung adenocarcinoma relapse? Are there biomarkers that are predictive of clinical outcome in squamous and small cell carcinomas? So as you all know that other than EGFR, MET exon 14 skipping or MET amplification has become an emerging biomarker, as we have the specific targeted therapy like crizotinib is there, cabozantinib is there, and so on. So finding patients with these MET exon 14 is critical because they cannot do just as well with the targeted treatment as ALK, ROS, and EGFR mutated patients. So different methodologies are there to detect MET overexpression, amplification, and exon 14 skipping. IHC for that matter, IHC has become very important. We can check by the Ventana benchmark, in particular with the protein MET with the Y1234 with /1235 and D26 antibodies. So for the IHC positive criterion, the concordance between four specific IHC cutoffs for CMET or PMET expression versus FISH is compared. And it was identified that IHC for CMET staining using H-score 200 as positive cutoff, and IHC provides a semi-quantitative indication of protein expression. So, but overall, NGS is the best method because it is looked at the mRNA level, because it is a fusion between the exon 13 and exon 15. So you get to see the exon 14 skipping mutations. So this FISH evaluation modified is according to the Skedals et al., where you can, by FISH, if you go to see the high level amplification, intermediate level amplification, and low level amplification. And these are based on the criteria ratio between the MET and CN7. So targeted treatment algorithm versus for stage 4 and metastatic NSCLC after positive findings on molecular tests. What are the biomarkers as per the NCCN guidelines? And here you can see a whole spectrum of targeted therapy available, like EGFR mutations, then for the ALK translocations, then ROS1 and BRAF. All these have now these are all the BRAF, RET, NTRK, MET exon 14, and KRAS G12C. These are the emerging biomarkers which are very important in the clinic. And as you all see that, other than that, you get to see the NTRK, HER2 mutation, exon 20 insertions mutations, as amivantamab is become very popular in the treatment of exon 20 insertions. So I can say here that there are many other biomarkers which are emerging in the research, but they're still not in the clinic. And these are the only basic biomarkers which need to be done in the clinic. Apart from that, you can add prognostic predictive biomarkers to look for, like STK11, TP53 mutations. Again, TP53 mutation is again becoming an emerging biomarker to identify whether the patient is going to have a good prognosis or bad prognosis. Earlier, you had some time back, you had the treatment for the TP53, but the clinical trials did not show very promising results. That is why I think at present the TP53 targeted therapy is not in the clinic, but still the clinical trials is on. And these, as I mentioned earlier, these are the main EGFR ALK cross one, and these are the various predictive alterations, and which are the methodologies you can use it for that. So for MET amplification mutation, as I mentioned, NGS is the best method, and for the amplification, MET amplification, FISH, real-time PCR and NGS are the best. So NGS outperforms PCR for exon 20 insertion mutation in NSCLC, as I mentioned earlier. The exon 20 loop insertions, you get to see the mutations at C-terminal loop of alpha C helix, to subgroups like exon 20 insertion near the loop and exon 20 insertion far loop. So these are the some of the insertions and duplications where you can see, and the deletion, which are far more important today in treating the patient. So the detection of genomic alterations is significantly directed by quality and quantity of starting sample material. Sorry for my bad throat. So now coming to the clinical samples, which are dilution of tumor DNA by non-tumor DNA, areas of necrosis, hemorrhage, extracellular mucin mark fibrosis in malignant bronchial biopsy samples, you can see. So mutations are harder to detect. There can be some false negative test or invalidates allele frequency data when there is a dilution of tumor DNA by non-tumor DNA. So it is mandatory to evaluate the tissue quantity and the quality before biomarker testing. So there are, as you all know, is a evolution of sequencing technologies has evolved, and you get to see, like from Sanger sequencing, pyro sequencing, and today we get to see the Illumina platforms, Nanopore, and also PacBio system. So these are the various platforms which are based on the sensitivity of the each technology. So the overall view of NGS technology is that, like, you prepare library preparation, then based on the read lengths, or either you can use long reads or short reads, and based on that you can have different types. Based on types of PCR, you can do the library preparation, and then you can put it on the available platforms over here. So these after once you get the raw data analysis, these are the various, after they are analyzed, we need to interpret with the various databases which are available, and the most I mean, the most prevalent and the most popularly used is the My Cancer Genome and the clinical interpretations of variants in the cancer. So these are the various databases, and the Jackson Laboratory also. These are the various databases which we can use. What are we currently doing with the single markers? As you all know, it is just not possible to do a single biomarker because tissues is an issue, and sequential testing is just not possible. 50% patients do not have any tissue specimen remaining after the first 4 biomarkers have been done. Then what is the emerging new biomarker now? So it is the liquid biopsy. It is the liquid biopsy which is being used, and as you can see, 1 in 5 patients with advanced NS molecular profiling performed with the initial biopsy, and 20% of those patients could not be re-biopsied. So circulating tumor DNA derived from blood could provide an alternative source of diagnostic material. Studies have shown that the tumor mutation burden based on the CGP, that is your genomic profiling, may be useful to guide the immunotherapy selection. At the time of selection of initial diagnosis in all patients who need tumor molecular profiling, actually the tissue biopsy is the best method. But if a patient is medically unfit for invasive tissue sampling, and if there is insufficient tissue for molecular analysis at disease progression, you can see overall that the 30% of the patients have inadequate tumor tissue for molecular analysis at diagnosis. So what are the guidelines, highlights from ESMO liquid biopsy guidelines? Liquid biopsy assays with very high analytical and clinical specificity may be used in practice with the limitations considered. A liquid first strategy is recommended as an alternative option to tissue genotyping, where time to result is clinically important or tissue biopsy is unavailable or inappropriate. So the blood sample should be collected when cancer is progressing, either treatment name or after prior lines of the therapy. So this is the real world data largely confirms high concordance between the liquid and the tissue biopsy, and it has been shown that the targetable mutations detected in 20% of liquid and 21.8% of tissue samples, as you can see the high concordance rate between the two. So this was the data which was presented with the 6,000 plus patients and who received the CGP testing in routine clinical practice. So it showed that the 90% of the patients with liquid testing showed evidence of ctDNA, and the median estimated ctDNA fraction was around 1.42%. So several liquid biopsy-based technologies are approved by the FDA and backed by the major guidelines. So today you can see that FDA approves COBA's EGFR mutation testing, IDLS, CT KRAS, and CT NRAS BRAF mutation testing receives the CE marking from the EMA for detecting all these KRAS, NRAS, and BRAF alterations in CRC. Foundation 1 liquid biopsy CDX, it's an FDA approved test, and you can see that they are performing the liquid biopsy testing regularly. And this year in Denver, now the major conferences are coming up which are highlighting only on the liquid biopsy testing. So the companion diagnostic indications, like you can look for the ALK rearrangement, you can look for the EGFR mutations other than other than these two biomarkers. You can also look for the fusions which can be seen in the ctDNA. So analysis of this ctDNA poses that ctDNA constitutes a highly variable fraction of the total plasma cfDNA from 0.1% to 90%. If ctDNA fraction is low, then the detection alteration is more challenging. But that's why it's need to be able to detect mutations down to less than 0.1% allele frequency, particularly for the detection of MRD. So it is more fragmented that at 134 to 144 base pair size. So it has a half short life, less than 1 hour in circulation. So what is the importance of this? What is the elevated tumor fraction? Why it is considered as a prognostic marker in the liquid biopsy? Because the characteristics of high shed tumors, higher the stage, it indicates higher stage metastasis, progressing on treatment, lung, breast, and GI cancers, it has become very popular. The characteristics of low shed tumors indicate that it is at lower stage, locally or locally advanced, responding well to the treatment, like in the various types of cancers. So in our prognostic value of plasma circulating tumor DNA fractions across 4 common cancer types have given very important results in the treating the patient. So plasma ctDNA tumor fraction is a pragmatic independent prognostic biomarker across 4 advanced cancer with potential to guidelines. So sensitivity of liquid biopsy to detect fusions, yes, retrospectively you can see in one of the studies that 131 paired tissue and liquid biopsy specimens were taken into consideration, and 92% of the fusion detection sensitivity was observed in liquid biopsy specimen with tumor fraction more than 1%. So why we should use tissue as a reflexant? Foundation Medicine Flatiron Health clinical genomic database analysis has showed that in first-time liquid biopsy of NSCLC, driver mutations are detected only in around 45% 90% of the samples, whereas the tissue reflex frequently detects the driver alterations following negative liquid comprehensive genomic profiling, and the NSCLC patient with alterations identified the tissue reflex experience clinical benefit on the targeted therapy. So you can see how important it is to use not only the liquid biopsy but to use the tissue reflex. And you can see the drivers identified after negative liquid biopsy testing. So the progression free survival, it is very useful to monitor the disease by the liquid biopsy, and this has become very important in the clinic. I won't go much into the detail of this. Yeah. So just to highlight, broad-based genomic testing with NGS optimizes a cost-efficient manner with the liquid biopsy testing available in advanced NSCLC while maximizing the diagnostic genomic information, though it remains a challenge. So there are multiple platforms, multiple technical details available. Many of them are used in clinical labs. Not all types of alterations are detected by individual NGS assays, and it is important to be familiar with the types of alterations identifiable in a single or combination of assays. Consider to use RNA-based NGS to maximize detection of gene rearrangements, especially if broad panel testings don't have identifiable driver oncogenes. So the plasma ctDNA testing has emerged as a complement to tumor tissue genotyping for advanced NSCLC, especially when tissue time is limited. The optimal way to integrate the ctDNA testing into diagnostic algorithm for patients with newly diagnosed NSCLC still remains clear. So in this, my presentation, I wanted to highlight that other than EGFR and ARC, which are known, the other emerging biomarkers are the various fusions like the RET, ROS, and TRAC fusions. And also, if you take a broader panel for as a prognosis or a predictive marker, you have some other TP53 and STK11 and so many clonal hematopoietic chips based method. So this was the short presentation of my today on the emerging biomarkers in lung cancer. So liquid biopsy still is a complement test along with the tissue biopsy for genomic profiling. Thank you so much.
Right. Thank you, ma'am. Thanks a lot. It was really a lucid presentation and leaves no questions to be asked. But I would like to ask one question. Like, still some time back, we used to do these next generation sequencing for these driver mutations only in adenocarcinoma.
Yeah.
But recently, the guidelines have recommended that even in squamous cell carcinomas also it to be done.
Correct.
So I just wanted to ask two questions: that what is your experience about the incidence of driver mutations in squamous cell carcinoma? And secondly, do you recommend in all squamous cell or in patients who are light smokers or never smokers? Thank you.
So thank you very much for this question. As I showed in my first paper, which published in PLOS One, so we not only did in the adenocarcinoma, but we in the squamous also we identified that there was around 3.8% of EGFR mutations present in that, and this was the paper which highlighted that we also got around 3.8% of the EGFR mutation in the squamous. So yes, we should do EGFR testing in all the squamous other than adenocarcinoma. And if you go to see, there are driver actionable mutations, like most of the EGFR mutations are mainly seen in the adenocarcinoma, but you can see EGFR amplification in the squamous cell carcinomas as well. So we have to do because many biomarkers, emerging biomarkers are coming up, like for the KRAS, G12C, TP53 mutations and all. So in all lung cancer, I think we should have this study of the profiling.
Okay. Thank you, ma'am. Thank you. Thanks a lot.
Yeah, I hope I satisfied your question.
Yeah, right. Yes, ma'am. Surely, ma'am.
Okay. Thank you.
Thank you so much, ma'am.
Yeah, thank you.
So second, I would like to invite Dr. Sameer Khatri, who's director at Max Parpadganj. He is my guide, my mentor, since I have started practicing in corporate with Sir only. So Sir would speak on addressing the role of atezolizumab in non-small cell lung cancer. Over to Sir.
Okay. Thank you, Amba. Thank you for inviting me for this talk. And without wasting much time, to start with the presentation. So, my screen is visible to all of you?
Yes, sir,
Yes,
visible.
sir. Yes, sir.
Yeah. Okay. So, very good evening. I will be talking about this atezolizumab data as far as the treatment of first-line NSCLC is concerned. These are my disclaimer, and I will be talking about the background, a quick background, and the evolving landscape as far as the lung cancer treatment is concerned. And I will be talking basically about these three studies: the IM Power 110, 1150, and 130, and how to conduct. So, as we all know, this NSCLC account for the 80 to 85% of all our patients, and 50%, 15% of these patients are never smokers. Median age about 65 to 70, and the metastasis occurs later in the disease. And 55% of patients they have a disease, distant metastasis at diagnosis. Targeted agents they have definitely evolved over the period of time and have improved the survival rate. As far as the treatment landscape is concerned, in 80s and 90s and even early 2000, we were giving chemotherapy. The classical, the Schiller's trial was there, and we were giving paclitaxel, gemcitabine, cisplatin, or carboplatin. And this was the only option available to us. And NSCLC, small cell lung cancer, this was the basically the two categorization. Now we have the histological subtype, and now we are talking about the molecular subtypes like EGFR, and the target changing. And all these improvements, all these data has improved the survival and PFS. Now the latest is the checkpoint inhibitors, the cancer immunotherapy. So definitely we all know about this thing that there is an unmet need as far as the treatment of NSCLC is concerned, especially in those patients who have no actionable biomarkers or the mutation. So targeted therapy has definitely improved the survival as far as if we see the graph different. No treatment, hardly any survival. With non-targeted cytotoxic, some improvement is there, but with targeted agents, the they definitely have a better prognosis. So today I will be talking about basically these three studies: the IM Power 110, 130, and 150. And with the basic difference, IM Power 130 is a study in which atezolizumab monotherapy was compared, and it was better, especially in those patients who had a PDL1 positive. 130 was a steroid sparing chemotherapy regimen that used the NAP paclitaxel, and 150 was very important study. We all know about this study, and in this, atezolizumab was added to paclitaxel along with bevacizumab, and how important it was. So, starting with this monotherapy of IM Power 130, and this is the trial design in which stage 4 non-squamous and squamous. So, this is the difference between other studies and this, that in 110, it was non-squamous and both categories were used, and this was selectively based on the treatment was based on the PDL1. And atezolizumab in a standard dosage every 2 weeks 1200 milligram was compared with amitriptyline carbo or cis in non-squamous and gem cis or carbo in squamous. And if we see the prevalence of PDL1, it was similar in both the TC or T or the tumor positive T or this IC3 wild type, and this was the T213 was again balanced in the 2. So these were the baseline characteristics. Important to remember is the male predominance in all the things. White patients were there in about 80% of the patients, in hardly 16 or 10% of the patients. Another important thing is that these were basically the smoker population, and 70% being the non-smoker. And if we see the result, the overall survival in TC3 or IC3 patients, that TC3 means that the tumor set it was positivity in more than 50% of the case, 50% health, and it was seeing the overall survival was much better. 12 years and 12 months and 6 months, the overall survival was much better as compared to the chemotherapy. So the median overall survival improved by approximately 7.1 months with Atizo over the chemotherapy, and median overall survival was 13.1 months. And if you see all the subgroups, so it benefited this single agent Atizo, it benefited all subgroups except for those who were never smokers. So it's very important, right? The smokers population was about 80-90% of the population were smokers, and those who never had a smoke, they didn't do so well. And also the elderly population, more than 75, they didn't do so well. Apart from that, all patients did well. And if we talk about this TC3 or IC3, after a longer follow-up, so that continued overall survival improvement of the single agent Atizo versus the chemotherapy arm. And this is the updated result to show that the 12 months overall survival 66.9. And again, this is showing the same thing, that the 35% of patients in the control arm, they receive subsequent chemotherapy. And this is the subsequent therapy. And the proportion of patients who receive different classes of subsequent chemotherapy, the cancer treatment was similar across the PDA. So again, if we talk about the hazard ratio, was more strongly favorable in terms of atezolizumab versus the chemotherapy if we adjust the subsequent immunotherapy uses. So if we again adjust according to that, then if you see the hazard ratio, it was 0.6 again. So this overall survival hazard ratio is more strongly favored, at least so, after adjusting for the effect of subsequent immunotherapy. And we have often talked about various forms how to test PDL1. So across all the things, if whether we are using SP142, SP2650, or 22C3, all the whatever the platform it is used, the patient benefited with the single agent fatigue. So again, this TC3, there was a clinically meaningful improvement in PFS, and PFS was not common to your ICT population due to hierarchical statistical plan. Another important thing is that the updated analysis which showed that there was a improvement in 6 months and 12 months PFS, and the hazard ratio was, as you can see, it was 0.5. And if we talk about the overall response rate, it again improved with Atizo versus the chemotherapy. So 40.2 versus 28.6. And again, these were the population which was a high PDL1 expression. And as far as the safety profile is concerned, the Atizo arm, it side effects as expected, more of immunotherapy related side effects or immune related side effects, much more as compared to the chemotherapy arm, but much well. And all cause adverse event, if you see the chemotherapy, it was more anemia, nausea, neutropenia, as is known with chemotherapy, constipation, thrombocytopenia, all were more common. But as far as the immunotherapy is concerned, increased AST, pruritus, hypothyroidism. So to summarize this study, the IMpower 110 study, the Atizo represents a promising first-line treatment option in patients who have high PDL1, especially those patients who don't want to take chemotherapy. And this study is a positive study as far as the overall survival is concerned, especially with TC3 or IC3 wild type patient. And the safety profile is consistent, and the Atizo had a favorable safety profile compared with the chemo. Now coming on to this 150 study, again important to remember, this is a non-squamous NSCLC patient, and here Atizo was added to the standard of care, that is chemotherapy and bevacizumab, and it was compared to basically the three arms were there: Atizo, Teclicarbo, Atizo with Teclicarbo and Bev, and Paclitaxel. So Paclitaxel was the standard of care, and this episode was added with key clinical questions which was there asked in this study were does this addition of episode to standard of care it has a added clinical advantage? Is there an improved clinical benefit if that is replaced by episode? And this is the maintenance therapy whether episode and that and change. And the fundamental behind this addition was that Atizo, we all know it has the ability to restore the anti-cancer immunity to the activation of the T-cell mediated response system killing. And this is further enhanced by bevacizumab. This is the VEGF inhibitor and it immunomodulates the effect. And this is the synergistic effect along with the chemotherapy. As you know, is the immunity. So these were the basic practitioners. They had a lower metastatic acquisition and were well balanced. And basically, this arm B and C, therefore, there was a significant overall, it was 24 months. To the hazard of 0.8. So months was usually 6. And if we talk about the duration of response, this was maximum when we added this Atizo with the chemotherapy and Beva. So arm B is much better as far as the duration of response was concerned. And a high proportion of these patients responded to this treatment, 56%. And if we talk about those patients who had a high PDL1, their response rate was as high as nearly 70%. And in low, it was about PDL1 negative. So this overall survival benefit was observed across all the PDL1 subgroup, and especially in those who had PDL1 high. And again, the same thing, the PDL1 positive patient subgroup treated. Now, very important thing and the interesting thing which came out from this trial was these patients of EGFR positive with CKI. And this is again the about 1200 odd patients were there and 1000 were wild type and 160 were the EGFR mutated or ALK mutated, and out of that EGFR mutation was in 124 patients and they had a sensitizing mutation in 91 patients. And TKIs were given, prior TKIs were given in about 78 patients. If we see the results of IMR, again, they were not a clinically meaningful PFS advantage, which was observed with arm B, that is a chemotherapy along with Atizo, as compared to chemotherapy alone in those patients who were EGFR mutation positive, L positive. So a hazard ratio of 0.5. So this is a trial which has shown again that even after EGFR TKI, if the patient progresses, then this is a good option, the IMpower 1. So overall survival benefit was there with the hazard ratio of 0.6, and there was a continued clear advantage. You can see these curves and the arm B and C, but arm A and C, they were more or less same and there was no advantage. So Atizo, Bev, along with chemotherapy arm, they had a overall survival benefit with sensitizing EGFR mutation with prior TKI. So if we talk about overall response rate and duration of response, they were again improved, 71 versus 42, and about 6% of the patients, they achieved a CR also. Now, another important factor which came out, the subgroup analysis which came out from this 150 study was the liver metastasis. And these patients who had liver metastasis, they had again clinically meaningful PFS advantage which TISO when added to the chemotherapy. So these patients with liver metastasis, they have a clinically meaningful advantage. And at 18 months, it was 23.3 versus 1.8. So drastic difference between the PFS and the two. And overall survival was also better in these patients who were there. Arm B at the group. But again, arm A and C, there was difference in the responses. Duration of response was again much better with the adhesive. Another important factor is the bulky disease. And how to define this bulky disease, is high burden disease or low burden disease. And definition, medium more than 30.5. That would be the definition based on the number of metastatic sites or the this SLD. So based on this also again this drug, the clinical benefit was there when so was added to the MCC in all these patients who had the bulky metastasis. So from 150 we can gather that met both its four primary endpoints, and it was the first and only phase 3 trial in which immunotherapy was added to anti-VEGF inhibitor and chemotherapy, and it demonstrated a significant and clinically meaningful improvement in both PFS and non and clinically meaningful PFS and OS benefit were observed in all patients, including subgroups like EGFR positive or liver metastasis, and this clinical benefit of addition of additive was observed in the patient with the bulky. So Atiso in combination with chemo and appears to be a well positive as far as the safety profile is concerned. And now coming on to the last study, this is the 130 study, and it has a arm which the chemotherapy was the NAP paclitaxel and carbo study with or without Atiso. So this again, this arm has a steroid sparing effect. So the rationale of combining or know about this is that Atiso, it has the ability to restore the anti-cancer immunity by select deactivation, and chemotherapy, it induces immunogenic cell death and cancer of tumor. All of this combination is to create a more favorable environment to maximize the potential cancer. So this is the study again on non-squamous years 0 and 1. The patient was specified according to sex, PD-L1 or the liver metastasis. So there's a use of this NAP actually in IM Power 130 study. It provides an alternative. An important thing is the steroid sparing chemotherapy regime, especially in those patients who have the diabetes, and standard dosage was there. Endpoint was the PFS and OS. This is the baseline characteristics. Again, female to male, more or less the same. Liver metastasis 15 and not basically 90% of these patients did not have a liver metastasis. White population was there in 90%. And again, this was the basically the and if we talk about the PFS, again it was improved. Landmark 12-month PFS is 14% versus 29% at 1 year. And if we talk about OS, then it was a improvement with Atiso and NAPACLI. And OS was significantly improved in this arm. And despite 59% of these patients who had received the subsequent immunotherapy. So even if patient has received subsequent immunotherapy on progression in chemotherapy, they also did. And as far as all the subgroup analysis is concerned, they did much better with this combination as compared to immunotherapy alone. And there was again no difference in PFS or OS in those patients who had EGFR and L. So this study again emphasizes the importance of the previous study we studied, the IM Power 150, and I think it remains the only phase 3 study to demonstrate the clinical benefit of chemotherapy and immunotherapy combination in patients who have progressed on EGFR. Overall response rate and duration of response, it was much better in Atizo arm, 50%, nearly 50% or 31%, and the CR rate, all were in favor of this. So Atizo, Aptacli, and Carbo, again, if we talk about very well tolerated, except for the immune side effects which we have. So to conclude this 130 IM Power 130 study, it was a positive phase 3 study, and this study it definitely demonstrated the significant and clinically meaningful OS advantage when Atizo was combined with Napatine and Carbo, despite a high crossover. And this study again demonstrated the PFS benefit and higher overall response rates. And this OS and PFS benefit was observed across all the key subgroups except those patients who were EGFR or positive and or patients with given. And this episode chemotherapy, they had a very good safety as in other studies. With this, I would like to thank you all for the patient listening. Thank you. Thank you.
Thank you, sir. Thanks for such detailed presentation of the role of Atizo. I just want to ask one question, sir. Like now, chemoimmunotherapy is the standard of care in metastatic non-small cell lung cancer. So, because we are giving chemotherapy also and immunotherapy also. So, what about steroid pre-medications? Are you giving the steroid pre-medications to these patients, or you're going without it?
As this IM Power 130, I like to avoid steroids whenever possible. So I am following this 130 study.
Sir, thank you, sir. So next, I'll be presenting the role of tepotinib in MET exon 14 skipping mutation. So can someone allow me to share the screen?
Yes, sir. Now you can see.
Okay. So as Dr. Anuradha has very clearly explained the role of molecular diagnostics in patients with non-small cell lung cancer. So understanding the molecular pathways has resulted in evolution of targeted therapy against actionable driver mutations, which have significantly improved the outcomes in patients with metastatic non-small cell lung cancer. Although the EGFR remains the most commonly diagnosed driver mutation amongst all, but MET accounts for around 3% of mutations in non-small cell lung cancer. And to detect MET, RNA-based next generation sequencing is highly sensitive as compared to DNA. So whenever we are ordering for next generation sequencing, we should consider both DNA plus RNA-based next generation sequencing. So these are the guidelines for non-small cell lung cancer, advanced or metastatic disease. So all patients, like till some time back, we used to get the next generation sequencing or this driver mutation diagnosis only in patients with adenocarcinoma or large cell carcinoma. But recently, the guidelines have added even squamous cell carcinoma for considering the molecular testing, because up to 8 to 10% of these patients may have actionable driver mutations, which might improve the outcomes in these patients too. Coming to MET exon 14 skipping non-small cell lung cancer, seems to be more in adenocarcinomas and non-smokers. So, as it is very much clear by this Kaplan-Meier survival curves that with the help of MET inhibitor, if given to these patients with MET exon 14 skipping mutations, the median overall survival is significantly better. It is 25, around 25 months vis-a-vis 8 months with chemotherapy. And also it was being seen with the when the comparison of the pooled analysis was done that these patients with advanced non-small cell lung cancer having exon 14 skipping mutations, either with the IO immunotherapy or IO plus chemotherapy, will not do well as compared to what they are doing better with the MET inhibitor, that is tepotinib. You can these Kaplan-Meier curves are very clear that patients, when offered MET inhibitor, that in the form of tepotinib, the median real-world overall survival is significantly improved, 29.7 vis-a-vis 18.9 months with the IO monotherapy or IO plus chemotherapy. So what NCCN guideline recommend? NCCN guideline recommend that patient with advanced or metastatic non-small cell lung cancer with MET exon 14 skipping metastatic non-small cell lung cancer should be offered first line therapy as either tepotinib or capmatinib. Both are MET inhibitors, and also crizotinib, because crizotinib work both on ALK, ROS, and MET. So it can also be given in certain circumstances when the patient is not able to afford tepotinib or capmatinib. And the same ESMO guidelines concurs with NCCN guidelines, and they also recommend patients to be offered a MET inhibitor, tepotinib or capmatinib in patients who are harboring MET exon 14 skipping mutations. So this is I'll be talking about the VISION study, which is the largest study of its own kind because it involves more than 300 patients with MET exon 14 skipping non-small cell lung cancer, and is the first clinical trial of MET inhibitor where the patients harboring MET exon skipping mutations, both on the basis of liquid and tissue biopsies, tumor or solid biopsy, were taken. Also, there were patients which were of the age more than 70 years. The median age of the patient was 70 years, but there were patients who were more than 80 years too. And one third of the patient, nearly about one third of the patient, were Asian. So this is the schema of this phase 2 study, where a patient with advanced or metastatic non-small cell lung cancer harboring MET exon skipping detected either by liquid or tumor biopsy, uh, who have not had received any MET inhibitor in the past, but might have had received 2 lines of prior therapy, were either they were offered tepotinib, that is tepotinib for 50 milligram per orally once daily. And on the right side, we can see the population, the baseline characteristics of, because both the patients who were treatment naive and previously treated with chemotherapy, they were there. Around 164 patients were treatment naive. There were 150, nearly 150 patients who were been previously treated. And you can see that there were many patients who were of age more than 75 years, and there were around 50% patients who were smokers, and there were adenocarcinoma patients, squamous as well as sarcomatoid, although the majority of the patients, more than 80%, were adenocarcinoma in both the groups. And one can also clearly see that around 36% of the patients were positive for this MET exons 14 mutation by liquid biopsy only, 42% with the solid biopsy only, and 21% with both liquid and solid biopsy. So this was the VISION study where the patients who were treatment naive, it has shown that the overall response rate with tepotinib was 58.6%, with the median duration of response of 26.4 months and median progression-free survival of 16 months, and median overall survival was around 30 months. And the patient who were being previously treated, they had an overall response rate of around 50%, median duration of response 10.2 months, and median progression-free survival of 11.5 months, and the median overall survival of 20.4 months. So tepotinib showed promising results with both treatment naive and previously treated patient, and also the patient who had brain metastasis. Around 57 patients in this study had brain metastasis, and more than 88% patient had disease control in the brain. You can see the intracranial response where few patients also achieved CR. So efficacy of tepotinib was significantly improved in patients who were treatment naive Asian patient. You can see the objective response rate, median duration response, median PFS, and median overall were more than what was being seen in non-Asian patients. Similarly, patients who were previously treated with some line of therapy, there also overall response rate, duration of response, PFS, and median overall survival was better than what was seen in non-Asian patients. So what about the patients who were elderly, who were more than 75 years? Tepotinib had given the benefit. The benefit was derived by all the subgroup of patients, irrespective of age, whether it was less than 75 or more than 75. We can see that 45% of patients were more than 75 years of age, and there the disease control rate was 75%, vis-a-vis 74.5% in patient with age less than 75 years. So even in elderly patient, tepotinib has shown robust and durable responses. So what about the adverse events in patients according to the age? So you can see that both less than 75 and more than 75 years of patient had some sort of adverse events, but the adverse event which were leading to the permanent discontinuation of the drug were only 10% in less than 75% and around 20% in more than 75%. Otherwise, patients, around one third of the patients did require temporary interruption, and around one third to 40% of the patient required dose reduction. So this is a matching adjusted indirect comparison of tepotinib and capmatinib. Both are MET inhibitors in patients with MET exon 14 skipping mutations. So previously published matching adjusted indirect comparison has shown that tepotinib as compared to capmatinib has offered prolonged progression-free survival and overall survival to patients as compared with crizotinib and capmatinib. And then updated MAIC analysis using tepotinib outcomes from larger patient population in vision with the data cutoff at November 22 and capmatinib geometry trial mono 1 has also revealed that patients on tepotinib are doing better as compared to capmatinib. So there's updated MAIC utilized data from patients with advanced MET exon 14 skipping mutation, where the two trials, Vision and Geometry trial, were undertaken. And it was, you can see that if we talk about PFS, the indirect comparison has shown that tepotinib is doing far better than capmatinib. With the median progression-free survival was 15.9 months, whereas 12.3 in capmatinib. And if you talk about overall survival, then it was around 30 months for tepotinib, and in geometry trial, it was 20.7 months. Now, in previously treated, that I was talking about treatment naive patient, in previously treated second line or subsequent line, you can see that tepotinib again doing better with a median PFS of 11.5 months and capmatinib in geometry doing only 5.4 months, whereas OS offered by tepotinib was 20.4 months and capmatinib was 13.7 months. So if we talk about the median PFS, it was 22 with tepotinib and 12.3 with capmatinib, and median OS was 29.7 and 20.7 in first line patient. And if you talk about overall response rate, yes, capmatinib seems to be offering more responses than tepotinib. But if you talk about duration of response, that is strikingly significantly higher in tepotinib patient, around 46.4 as compared to 12.6% in capmatinib. So these are the MET TKIs for patient with MET exon 14 with brain metastasis. You can see that CNS overall response rate was 54% in geometry trial, where it was 66.7 with the CNS disease control rate 88.4 in tepotinib. So tepotinib doing well even in patient with brain metastasis, also the patient without brain metastasis. So this is the current therapeutic landscape in patients with exons 14 skipping mutations. Available drugs, we have tepotinib, we have capmatinib, and we have savolitinib, which presently not available. So in vision trial, we can see that uh, patients are achieving more benefit as compared to the capmatinib in geometry trial. If you talk about first line, the median PFS and overall survival is 15.9 and 29.7 respectively in first line, as compared to 12.5 and 25.5 PFS and OS in first line in capmatinib. Whereas if you talk about second line, it was 11.5 and 20.4 in tepotinib. That is vision trial, whereas in geometry it is 5.5 months as compared to 11.5 months, and 13.6 as compared to 20.4 of tepotinib. So also tepotinib offers convenience of dosing because there is once daily dose, so only 2 tablets, whereas capmatinib has to be taken twice daily, so 4 tablets have to be taken. And as I said, that tepotinib, around one-third of the patient had to undergo the dose reduction. So that patient's 2 tablet had to be halved. That it means 1 tablet has to be taken once daily. That is 450 has to be done 225. Quite complicated dose reduction schedule of capmatinib. So to summarize that, we know that lung cancer is most commonly diagnosed malignancy amongst males in India as well as worldwide, and the emerging molecular biomarkers and actionable driver mutations and the evolution of targeted therapy have significantly improved the outcomes in these patients as compared to the chemotherapy. So MET exon 14 skipping mutation is one of the actionable driver mutation, and there has been an unmet need for these patients. MET targeting TKIs are recommended as first line standard of care because we can see in both geometry trial as well as vision trial, patients doing better in the term of PFS and overall survival in first line rather than the subsequent line. Tepotinib has demonstrated robust lasting efficacy in the treatment naive and previously treated patients enrolled in vision stated, irrespective of the brain's metastasis, and Asian patients doing numerically better than non-Asian patients. The indirect comparisons have confirmed the clinical benefit of tepotinib in comparison with capmatinib in patients with advanced MET exon 14 skipping non-small cell lung cancer. So conservative measures and dose reduction, which is required in around one-third of the patient, otherwise the drug is well tolerable, can be, so this drug with little bit of dose reduction or interruptions in few patients can be used proactively to manage the adverse events and the edema, which is one of the side effects in patients receiving MET inhibitors. And also this drug should be offered as upfront therapy in patients with exon 14 skipping non-small cell lung cancer in view of the better results as shown in vision as well as the geometry trial with tepotinib and capmatinib. Thank you. So if there are no questions for next talk, I would like to call upon Dr. Megha, who is Senior Resident Medical Oncology at Metro Hospital and Cancer Institute. So she'll speak on the role of immunotherapy in advanced non-small cell lung cancer. Dr. Megha.
Uh, Good evening, sir. Am I audible?
Yes, yes. Please carry on.
Okay. So I'll be talking about role of immunotherapy in metastatic non-small cell lung cancer. So the treatment of advanced or metastatic non-small cell lung cancer depends on various factors, one being presence or absence of biomarkers and the level of expression of the same, which includes PD-L1, tumor mutational burden, Second being histology, whether it is non-squamous or squamous cell carcinoma. And third being mutation status, which should include EGFR, ALK, ROS1, RET, MET, etc. Now, the current treatment protocol, as mentioned, depends on the histology, whether it is non-squamous or squamous cell carcinoma. For non-squamous cell carcinoma, testing for targetable oncogenic driver alteration is recommended. However, it is to be considered in squamous cell carcinoma as well. If any targetable driver alteration is present, then targeted therapy is to be given. If it is not present in squamous cell carcinoma also, PDL1 testing is to be done. And further treatment depends on the level of expression of PDL1, whether it is more than 50% or less than 50%. Now, the incidence of PDL1 expression, high PDL1 expression, that is TPS more than 50%, is found in approximately 30% of advanced non-small cell lung carcinoma. The low PDL1 expression is found in approximately 44%, and absent PDL1 expression or no PDL1 expression, that is TPS less than 1%, is found in approximately 26% of patients with advanced non-small cell lung carcinoma. There are various PDL1 testing platforms which are used for the testing of PDL1 expression in different drugs. So for nivolumab, IHC 288, and for pembrolizumab 22C3, for atezolizumab SP142, and for durvalumab SP263 assay is used. Now, there were various blueprint projects that had investigated the interchangeability of assays regarding their analytical and clinical diagnostic performances. And it was found that there was high concordance and interchangeability of 22C3, 28.8, and SP263 assays when scoring tumor cells. However, SP142 appeared to stain less tumor cells as compared to the other assays. Now, talking about the treatment part, in tumors with PDL1 high expression, that is TPS more than 50%, immunotherapy, monotherapy is preferred as compared to chemoimmunotherapy. So for ICI monotherapy, the agents which are preferred include pembrolizumab based on Keynote 024. Other drugs that are preferred are atezolizumab and semiplimab. Whereas chemoimmunotherapy, that is the combination of chemotherapy and immunotherapy, is preferred in patients with rapidly progressive, symptomatic, or high tumor burden with impending symptoms. And these include chemotherapy in combination with either pembrolizumab, semiplimab, or atezolizumab. And one other option that can be given to the patients is combination of nivolumab plus ipilimumab in patients who are not candidates for chemotherapy or who don't prefer chemotherapy. The role of pembrolizumab monotherapy in advanced non-small cell lung cancer with high PD-L1 expression is based on phase 3 Keynote 024 trial, where patients with stage 4 non-small cell lung cancer were randomized to either pembrolizumab monotherapy or histology-based chemotherapy. And it was found that with pembrolizumab monotherapy, there was statistically significant improvement in both progression-free survival and overall survival, with hazard ratio being 0.54 and 0.63 respectively. And the role of atezolizumab monotherapy in NSCLC patients was based on the results of phase 3 IM Power 110 trial, where patients with chemotherapy naive, advanced non-squamous or squamous non-small cell lung cancer were randomized to either atezolizumab monotherapy or histology-based chemotherapy. And it was found that the overall survival was statistically significantly improved with atezolizumab monotherapy as compared to chemotherapy alone. And thirdly, the role of semiplimab monotherapy was established on the basis of Empower Lung 1 trial, where advanced non-small cell lung cancer patients with PDL1 more than 50% were randomized to either semiplimab monotherapy or platinum doublet chemotherapy. And again, it was found that with the usage of semiplimab monotherapy, overall survival was much improved in comparison to chemotherapy alone. So this was about patients expressing PDL1 high. In patients with low level of PDL1 expression, that is less than 50%, or unknown PDL1 status or unselected tumors, we have treatment regimens based on the histology of the tumor. If it is non-squamous non-small cell lung carcinoma, then pembrolizumab with pemetrexed and carboplatin, and ABCP, that is atezolizumab with bevacizumab, carboplatin and paclitaxel, or atezolizumab with carboplatin and nab-paclitaxel are preferred. In case of squamous cell carcinoma, pembrolizumab with carboplatin and taxane is preferred based on Keynote 407. And other options that we have are nivolumab plus ipilimumab, nivo plus EP plus chemotherapy, cemiplimab plus chemotherapy, and combination of tremelimumab plus durvalumab plus chemotherapy. The role of pembrolizumab plus chemotherapy in first-line setting in non-squamous non-small cell lung carcinoma patients was established on the basis of Keynote 189 trial, where patients with non-squamous advanced lung carcinomas were randomized to either pembro plus chemo or placebo plus chemotherapy. And it was found that with the combination of chemoimmunotherapy, there was improvement in terms of both progression-free survival and overall survival, with the hazard ratio being 0.52 and 0.49 respectively. The benefit in terms of overall survival was seen in across all the subgroups of TPS expression. However, the benefit was much more pronounced in cases where TPS was more than 50%. Same goes for PFS. However, in cases where TPS was less than 1%, the benefit was not that much. However, it was quite pronounced in cases with TPS more than 50%, as we can see with the separation of the curves. Now, the role of ABCP regimen, that is atezolizumab plus Bev plus Carbo plus Pacli, was on the basis of phase 3 IM Power 150 trial, where patients with stage 4 or recurrent metastatic non-squamous lung carcinoma patients were randomized to 3 arms. One being atezolizumab plus carboplatin plus paclitaxel, second being ABCP, and third being BCP. The ABCP arm was compared with BCP arm in terms of results, and it was found that PFS and OS were improved with ABCP as compared to BCP, where the median PFS was 8.3 months with the ABCP and 6.8 with Bev plus Carbo plus Pacli. And the benefit with ABCP regimen was seen across all the subgroups of patients, whether it was EGFR or ALK positive or wild type, and in all the TPS expressions. Now, the role of atezolizumab with carboplatin with the albumin-bound paclitaxel was also evaluated in non-squamous non-small cell lung carcinoma patients, and it was done in IM Power 130 trial, where patients were randomized to either atezolizumab plus carbo plus nab-pacli or carbo plus nab-paclitaxel. And it was seen that with the addition of atezolizumab to the chemotherapy, there was improvement in terms of both progression-free survival and overall survival, with the hazard ratio being 0.64 in terms of PFS. This was about non-squamous cell carcinoma. In squamous cell carcinoma, the role of pembrolizumab with chemotherapy was established in Keynote 407 trial, where patients with stage 4 disease were randomized to either pembrolizumab plus chemotherapy or placebo plus chemotherapy. Chemotherapy being carboplatin plus paclitaxel. And it was seen that with the addition of immunotherapy, the PFS was much improved as compared to chemotherapy alone. Also, the overall response rate was around 58.4% with chemoimmunotherapy as compared to only 35% with chemotherapy, and the result was statistically significant. Now, the benefit in terms of PFS was seen in across all the subgroups. Then again, the benefit was much pronounced with TPS more than 50%. OS was also improved with the addition of immunotherapy to chemotherapy. And this benefit was again seen in all the subgroups of patients in all the PDL1 expression cases. Lastly, the role of nivolumab plus ipilimumab in advanced non-small cell lung carcinoma was given by Checkmate 227 trial, where patients with both high PDL1 expression and low PDL1 expression were randomized to three arms. One being nivo plus ipilimumab, second being histology-based chemotherapy, third being nivolumab monotherapy in high PDL1 expression or intermediate PDL1 expression, and nivo plus histology-based chemotherapy in no PDL1 expression. It was seen that the overall survival was improved with combination of nivolumab plus ipilimumab across all the subgroups of patients in terms of PDL1 expression, whether it was less than 1% or more than 1% as compared to chemotherapy alone. So, concluding the presentation, so advanced non-small cell lung carcinoma should undergo evaluation for targetable driver alterations before any decision making is done based on PDL1. However, if the PDL1 is more than 50%, then immunotherapy, monotherapy is preferred. However, it can be combined with chemotherapy depending on burden of disease and pace of progression. In cases where PDL1 is less than 50% or there is unknown PDL1 status or unselected PDL1, combination of chemotherapy with immunotherapy is preferred, or we can also go with nivolumab plus ipilimumab. Now, the immunotherapy is to be given for at least 2 years or until progression or unacceptable toxicity is there. And also there is this another drug, toripalimab, which is upcoming, which is cost effective and can be explored in future scenario. Thank you.
Okay. Thank you, Megha. You have given a very clear and very detailed overview of role of immunotherapy. As we know that there are studies where the use of steroid, that is prednisolone, more than 10 mg has shown adverse benefits in the term or the negative impact on the efficacy of immunotherapy. So, are you people using steroids in the patient whom you are giving chemoimmunotherapy? Okay. So anyhow, I think Dr. Megha is not here. Like, so next I would like to call, uh, yes, Dr. Megha, would you like to answer? Are you
Yes, sir,
people,
sorry, my network was not working well. Can you please repeat your question?
are you using steroids in patients whom you are offering chemoimmunotherapy? Because there are multiple studies where the use of prednisolone more than 10 mg has shown negative impact on efficacy of immunotherapy.
No, sir, in using immunotherapy, we are not using steroids as of now. Only in chemotherapy we are using, only while giving chemotherapy.
Okay. Okay. So next, I would like to call Dr. Shefali, who's Associate Director at Max. She'll be addressing the role of trastuzumab deruxtecan, that is Enhertu, in HER2 expressing tumors. Over to Madam.
Thank you, Dr. Dubey, and good evening to everyone. And let me share my slides. Yeah. Mm. So, are my slides visible?
Yes, ma'am.
Yes, Madam. Yes, ma'am.
Okay. All right. So, as Dr. Dubey mentioned, that I will be discussing the role of trastuzumab deruxtecan in HER2 expressing tumor. I think a wonderful drug, a revolutionary drug, which was required. It has changed the treatment armamentarium of not only breast cancer, but wherever we have HER2 positive expressing tumors, actually, whether it is GI, whether it is any other organ, I think this drug has made a remarkable difference in treatment. Of course, the concept of HER2 low or ultra low, we are exploring only in breast till now. but the tumors, I mean, which are HER2 amplified, this drug is causing wonderful response. Um, I'll be discussing my slides in a broad manner on trastuzumab deruxtecan in management of HER2 positive metastatic breast cancer, its role and implications in HER2 low and ultra low, and then I'll conclude my slides. So, trastuzumab deruxtecan, while treating HER2 expressing breast cancer, we know that we had wonderful drugs to treat HER2 positive breast cancer in the metastatic setting. We begin with the THP kind of protocol, that is Cleopatra regimen. Then in the second line, we had TDM1, or then followed by lapatinib or capecitabine. Then we had neratinib trial. We had, I mean, other wonderful drugs. We had then TDXD and tucatinib. So, I mean, how to sequence them and how to use it one after the other, I mean, is a wonderful sequence where we see TDXD has made its way in the post-trastuzumab setting very well. So, TDXD, as we can see with this slide, was designed with key couple of points in mind. And one of the important pointer was actually this is antibody drug conjugate, where the antibody is actually combined with a topoisomerase 1 inhibitor, and which is directly delivered into the tumor cells with a high potency of payload, and there is a good drug to antibody ratio in the tune of 8:1. So that ensures that the drug is delivered directly into the tumor cells and accumulated in a great strength to kill the tumor cells. That is how the response rate is also seen. And the one good aspect of this antibody drug conjugate is it has a tumor selective cleavable linker, and it has a bystander anti-tumor effect also. And now what is that bystander effect is, irrespective of whether the, I mean, neighboring tumor cells express HER2 or not, this drug has the capacity to permeate through the cell membrane into those cells and kill those cells also. So that is how this drug works. Now, just one second, the slides. Yeah. So we know that mechanism of action of trastuzumab deruxtecan is based upon these kind of the key pointers which were kept in mind while designing this drug. So if you see that this drug enters into the tumor cells through that receptor, and once it is internalized, the linker is cleaved directly into the plasma, directly into the cytoplasm actually, and then this drug, the topoisomerase inhibitor, so this drug works inside the cell, as well as once this work is done, this molecule is released because it is permeable, membrane permeable, and with the bystander effect, it has an anti-tumor effect on the neighboring tumor cells also. So that is how the TDXD demonstrated a response to therapy in 60% of the pretreated population with HER2 positive metastatic breast cancer. So, the Destiny Breast 03, which was an open label multi-center phase 3 study, this actually saw that the patients in post-trastuzumab and taxane setting, which were HER2 positive breast cancers, and the patients with clinically stable treated brain metastasis were also allowed. And if they were treated, there has to be a 2 or more than 2 weeks gap between the end of radiation and the patient enrollment in the study. So they were randomized into 1:1 fashion to TDXD and TDM1, and which is the standard of care actually before TDXD, into the second line once the patient progressed on trastuzumab containing regimen. So the primary endpoint they studied was PFS, and followed by secondary endpoint of overall survival, response rate, and duration of response. And they both included and tried to stratify the factors according to the hormone receptor status in the patients who actually utilize pertuzumab. What is the effect of TDXD in them, and does visceral disease make a difference in these kind of patient apart for having that brain metastasis? So if we see that demographics, the 50% of the patients included were hormone positive, 15% of them had a baseline brain metastasis, 70% had visceral disease, and actually out of all the patients included, 60% received pertuzumab prior to the enrollment here. And they all had median 2 lines of prior therapy. So if we see these graphs, we can see that the median PFS by blinded independent committee review in the TDXD arm was 28.8 months as compared to 6.8 months in the TDM1, and impressive hazard ratio of 0.33. in such a aggressive disease, once some drug has these kind of impressive results, obviously it is taken that it will make its way through, I mean, from say refractory setting to third line to the second line like that. And if we see the overall survival, it was not reached in the TDXD as and similarly not reached in the TDM1 arm. But the hazard ratio they calculated as per the stratification was 0.64. So again, if we see that patients who actually in the post-trial setting who post TDXD received TDM1 was 35% in that arm, and actually they who received TDM1 only 17% could receive TDXD post that. So coming to the side effects, the adverse effects, we know that one major concern with TDXD is ILD actually, and other things are more or less are easily manageable, including the nausea, vomiting, and neutropenia. So, ILD, as we are using this drug routinely, we are getting aware and acquainted to management of ILD also. The important crux bottom line is the earlier you pick up ILD, more easier it is to manage. So, if we see the further key subgroups of interest in this trial according to age and brain metastasis, so you can see from this graph that irrespective of age, TDXD was equally effective. So, in patients less than 65 versus more than 75, the efficacy was maintained. There was not much difference. And if you see the HER2 positive metastatic breast cancer age specified pool analysis, so the rates of adjudicated ILD pneumonitis were higher in patients more than 65 years of age across all trials compared to patients less than 65 years of age. Most drug-related ILD or pneumonitis cases were actually low grade. There was no grade 4 or 5 cases reported, and that much. So adverse effect other than ILD in patients more than 65 years of age, so they experienced more than, I mean, more grade 3 or more side effects, which is understandable as per the age and comorbidity concerns they have. Um, if we see the exploratory analysis for CNS PFS in this trial, we can see that the patients who had treated or stable brain metastasis, their TDXD had a median PFS of 12.3 versus 8.7 months in the comparator arm with a hazard ratio of 0.59. And also the patients who had untreated or active brain metastasis, actually they also did well in the TDXD arm with 18.5 months of PFS as compared to 4 months in the comparator arm with a hazard ratio of 0.19. So with a such kind of active brain metastasis in a such deadly disease, so this kind of response is actually revolutionary. And if we see the best percentage change from baseline in HER2 positive MBC, the pooled brain mets analysis showed that in TDXD arm, actually the shrinkage of brain metastasis was more prominent as compared to the comparator arm, which showed less kind of durable or deep responses. So similarly, TDXD in HER2 positive brain metastasis or leptomeningeal disease, we have two studies, the Tuxedo and the Rosette BM study. So newly diagnosed brain metastasis or progressive disease after prior treatment who received actually trastuzumab and pertuzumab in the previous line and where TDM1 was also allowed. So the kind of 73.3% intracranial response is really impressive. So having said that, these kind of results actually redefine HER2 as a therapeutic biomarker. Now we have such good drugs available to cater to this HER2 positive disease. Now, what about the patients who have HER2 low or its clinical implications? So, the main problem with HER2 low breast cancer is actually the lack of centralized definition for what is actually HER2 low. Because for HER2 low, we are more dependent on IHC, which is again subjective dependent. And IHC score of 1 plus or 2 plus FISH negative is actually classified as HER2 low. So the reporting of IHC is basic crux in these HER2 low cancers. So the incidence of HER2 low is approximately 43% in non-metastatic and nearly 55% in the metastatic setting. And HER2 low tumors are more frequently found within the HER2 negative and hormone positive basically, and the incidence is 65% as compared to triple negative where incidence is 37%. And majority of HER2 negative breast cancer are actually HER2 low. So there are very few who are actually HER2 zero or ultra low. So, like I already discussed, there are some challenges for interpretation of HER2 low breast cancer. That is why it took a long time to actually see the results, and efficacy is not similar or in concordance in every trial. So the most important challenge is there is no proper definition of HER2 low actually, because no formally established clear parameters were defining the HER2 low status. There was a lack of awareness initially between the pathologists, so we were reporting only positive or negative at many of the places. Now they have made a point to report it as at least 1 plus, 2 plus, or 3 plus, and according to the FISH categorization. Tumor quality is one major issue. So, doing biopsy, preserving the tissue, reporting it on time, actually, these are major challenges in some of the centers. Of course, we know that tumor heterogeneity in breast cancer plays very important role. At some hotspots, it may be HER2 2 plus, it may be HER2 1 plus at some hotspots. So, tumor heterogeneity is again very important limitation to report that. So if we see that trastuzumab deruxtecan efficacy in HER2 low breast cancer, so we can see according to the subgroup in that chart that if it is IHC2 plus, it was the response rate was of 38.5%. And if it is IHC1 plus, it was 35.7%. So actually this drug was not only working in HER2 amplified group, but also in the HER2 2 plus or 1 plus subgroups also. That is why, I mean, the trial was designed in HER2 low breast cancer to see this efficacy. And it was Destiny Breast 04 trial, which was open label multicenter phase 3 study. And it actually included the patient with HER2 low, which was defined as IHC1 plus or IHC2 plus FISH negative, unresectable or metastatic, with receiving 1 to 2 prior lines of chemotherapy in the metastatic setting. And her hormone positive disease who have actually received 2 lines of at least endocrine therapy and were endocrine refractory were also included in this trial. And the patients were randomized in 2:1 fashion to TDXD and treatment of physician choice, which included capecitabine, eribulin, gem, Pacli, and these kind of chemotherapies, which we generally end up doing in third or fourth line settings. And they try to see the PFS and OS advantages with this drug. So if you see the efficacy of TDXD in Destiny 04, so we can see that median PFS with TDXD in hormone positive group was even 10.1 months as compared to the treatment of physician choice, which was 5.4 months. And in all patient in intention to treat analysis, it was 9.9 months versus 5.1 months. So in the HER2 low subgroup also, this drug was actually working wonderfully well. And if we see the updated progression-free survival by investigator, so we can see that this difference was still maintained with 9.6 months in the TDXD arm in the hormone positive cohort as compared to 4.2 months in the treatment of physician choice. And in all patients included, it was 8.8 versus 4.2 months. So, updated overall survival, if we see that TDXD had a 23.9 months of median overall survival in the hormone positive cohort as compared to 17.5 months in the treatment of physician choice. And in all patients, it was 23.4 versus 16.8. Having said that, it means that TDXD was working irrespective of the hormone status in these kind of patients. And if we see the results, in phase 3 Destiny 04 in terms of HER2 low metastatic breast cancer in the hormone negative subgroup, we can see that TDXD had a median PFS of 8.5 versus 2.9 months. Actually, the delta was more here. And in overall patients, in overall survival, we can see that the results were very impressive again. So TDXD having 18.2 months of median OS versus 8.3 months in the treatment of physician choice. So again, if we see the adverse event profile, ILD again scores over and above other kind of adverse events, and the incidence was almost similar. Majority of the patients had grade 1, grade up to grade 3. None had grade 4, and 4 patients, that is 1% of the population, had even grade 5 event also. So otherwise, they were more or less similar if we see the other kind of side effects. So if we see the activity of trastuzumab deruxtecan according to HER2 IHC levels from Destiny 04 trial, we could see that IHC 1 plus or 2 with the FISH negative. So the almost hazard ratio was favoring that TDXD drug. So there was no major differences in PFS. This slide, I think, is very busy. I also can't read it out much. Sorry for that. And if we see that HER2 low expression is, may change from early to late stage disease, it's a dynamic expression. However, across the subgroups, no major difference in survival was seen when this drug was used. That is why it was approved in the HER2 low and ultra low for the treatment of metastatic breast cancer. So actually, the challenge was basically the IHC results from the central committee versus the labs, and it was good to see that even if there was discordance in some of the patients in reporting these results, however, the efficacy was not majorly different according to the test reported. So we can safely rely on whether it is reported in a peripheral center about HER2 low. So this drug can be used in that setting in those patients also. So now I think once we are using this drug routinely, so we are more wiser how to manage the interstitial lung disease. The bottom line is to catch it early. So as soon as you suspect any respiratory symptoms in these patients and monitor the saturation, make the patient more aware and educated about these symptoms, and tell them to report to you as early as possible as soon as they recognize that they have that respiratory difficulty, and you initiate the steroids wherever they are needed, that is grade 2 toxicity and where they are symptomatic. For grade 1 asymptomatic patients, so if you consider corticosteroid treatment as soon as possible, as soon as ILD is suspected and you see the changes on HRCT, the early ILD changes. So the dose is 0.5 milligram per kg prednisolone or equivalent, and you monitor that. I think ILD is well managed at that point. If the patient becomes symptomatic or if it is grade more than equal to 2, so after discontinuation of TDXD, the dose of steroid initiated is more than equal to 1 milligram per kg prednisolone or equivalent. Manage the steroids, cover the secondary infections if you see that that is a possibility. If the side effects of ILD resolve to grade 1 or less in less than 28 days from the date of onset, we generally, it is recommended that the same dose maintenance can be given. However, if it takes more time to resolve, you have to reduce the dose to one reduced dose level. So first initial dose reduction recommended is 4.4 milligram per kg, and final dose reduction beyond which they say that it should be discontinued is 3.2 milligram per kg body weight. And we should keep in mind that we should not re-escalate TDXD after a dose reduction is made. And the patients treated with TDXD should have HRCT scans at least every 12 weeks. And if the patient is symptomatic, you can do even it as every 6 to 9 weeks. So keep it in mind, earlier the detection, more easier it is to manage ILD. So to summarize, we know that HER2 is a dynamic marker which can demonstrate intra and intertumoral heterogeneity, and it may also change from early stage to late stage. The proportion of HER2 low is higher in hormone positive to the tune of 65% as compared to TNBC where it is 37%. Destiny Breast 04 showed significantly better PFS and OS in patients with HER2 low MBC who were treated with one or more lines of chemotherapy with similar magnitude of benefit across all subgroups, including HER2 IHC status 1 plus or 2 plus FISH negative, or even the prior CDK4/6 inhibitors used. So based on Destiny Breast 04 data, TDXT has been approved in majority of countries, including US, FDA, EU, and Canada, Australia, and now in India also. TDXD is also recommended for HER2 low MBC by NCC and NSMO guidelines. I think I'll stop my talk here. If any questions, I'll be happy to answer.
Thank you, ma'am.
Thank you so
So,
much. Yeah.
as you have already mentioned, a wonderful drug. I can say that revolution in the treatment paradigm of HER2 positive
Yeah,
cancers, but a worrisome adverse event, that is ILD. So, what is
absolutely.
your experience in your clinical practice? Like, how many patients have you seen whom you have started on Enhertu, and you were being able to catch ILD at an asymptomatic stage, that with PFT or imaging?
Yeah, so not many patients I have used. I remember only two patients. So one was, I think, both of them in breast. Yeah. So one patient had a progressive disease after 2 cycles, and she actually had a starting of TDXD outside of my center in HER2 low setting, metastatic breast cancer. She was hormone positive, endocrine refractory, post 3 lines endocrine therapy, and they started on. And then she continued with me. But unfortunately, I mean, beyond 4th cycle, I think she had a massive progression in liver, so succumbed to the disease. And the second patient, I think, did fairly well again for 3 to 4 cycles and had a progression again. But I mean, both of them did not have ILD. Probably they didn't have much of the time to have that ILD. So both of them had a progressive disease, could not do well. That was my experience. I have not used it in many of my patients.
Like, ma'am, you would have surely shared with your colleagues and all. Like,
Yeah.
is the trial data similar to whatever we are seeing in the real world setting or in our daily practice setting?
Absolutely, absolutely. There is no doubt about that. I have used it in actually three patients. So the third one was actually had a very surprisingly actually had a complete response on THP after 4 cycles, but after six she progressed. So I was very surprised that this kind of response we generally do not see. They are durable responses. But actually, when I did a NGS to see, she had a I think FGFR mutation, which was actually responsible for the resistance to HER2. But surprisingly, she did again well on TDXD, and she had a CR again after 4 cycles of TDXD. Now I have given her the protocol to continue 4 more, and then I'll reassess again. So that is how one patient is doing well. So I don't see any kind of say inhibition or resistance to use it in HER2 amplified post trastuzumab. That is a wonderful drug, and there can be majority of durable and remarkable responses. So exceptions are always there. There can be resistance pathways, so we should be ready to check it wherever we find why this drug is not responding, because there has to be some major reason in HER2 amplified actually. That is how it is.
Thank you, ma'am. Thanks a lot.
Right.
So
Thank you.
next, I would
Thank
like to call Dr. Pooja Babbar, who's consultant medical oncology at CK Birla Hospital, Delhi. So she'll be speaking again on HER2 positive breast cancer, a flexible future transforming the paradigm of HER2 positive breast cancer treatment. Dr. Pooja, madam, please.
Hello, sir. Good evening. And thank you for giving me this opportunity to present a talk on impact of subcutaneous dual HER2 blockage on patients with HER2 positive breast cancer. So is my slide visible?
Yes, madam, it's visible.
Okay. Yeah. So, slide courtesy by Roche. Achieving a PAT CR with neoadjuvant chemotherapy result in longer survival benefit than having residual disease. So we have seen that PAT CR, especially in TNBC and HER2 positive, is a surrogate marker of EFS. And as we add pertuzumab to trastuzumab, and uh, we have seen in few phase 3 trials that it has shown improvement in PAT-CR up to 65%. So patient who are receiving neoadjuvant PER2 and Herceptin has improved event-free survival, as we can see in the trials. And because of the addition of pertuzumab in
Ma'am, slides
neoadjuvant,
are not moving. Kindly make it slide.
is it moving now?
No, ma'am.
Okay. So can you share the slides?
Yes, ma'am.
Yeah. Now, is it moving?
Yes,
Yes, ma'am, it is moving.
Okay. So, event-free survival in patients with early HER2 positive breast cancer with a PAT-CR after HER2 targeted therapy. So, what we have seen that when we add pertuzumab to Herceptin, to trastuzumab, we see that patient with event-free survival event reduces, and without EFS event increases, and that is regardless of PAT-CR status. So we have a very nice study, which is a cardiac safety study of neoadjuvant pertuzumab and trastuzumab and chemotherapy, followed by adjuvant anti-HER2 therapy in HER2 positive early breast cancer. And we can see the incidence of cardiac events are actually between, the NYHA class 3 and 4 is close to 1.5. We have seen 0.5 to 1.5% at max. And the final analysis of phase 3 Peony trial, which is a trial to assess the efficacy, safety, and tolerability of PH and docetaxel for patient with early and locally advanced HER2 positive breast cancer. So it is very well matching with the trial in terms of PAT-CR, as we can see in terms of event-free survival, and also in terms of
कर लीजिए हम Ma'am is rejoining in 2 minutes.
yeah. Can you move to the next slide? Yeah, next slide. Next slide. Next. Yeah, next slide. Yeah, next slide. Yeah, next. So what is the current status of dual HER2 blockage? Next slide. So as we know, in a neoadjuvant and adjuvant setting, uh, we use dual anti-HER2 targeted therapy, that is trastuzumab plus pertuzumab in combination with chemotherapy in pre-op and adjuvant setting. And if the residual disease is there after pre-op therapy, we use TDM1 alone. Next slide. Yeah. So as we know, in the adjuvant setting, after giving NSCT, if patient has node positive disease, then adjuvant chemotherapy with Trastu and Per2 is used. Next slide. So again, the adjuvant therapy, if the node is positive and if there is a tumor size more than 2 centimeter, we give trastuzumab in combination with pertuzumab, which is category 1. Next slide. Yeah, so even in metastatic setting, as we know, pertuzumab and trastuzumab is given with single agent chemotherapy, which could either be docetaxel or paclitaxel. Next slide. Yeah, so this is ESMO guideline for early breast cancer. And we can see that patient whose disease is more than CT2 and node positive, we usually give neoadjuvant chemotherapy with anti-HER2 trastuzumab plus pertuzumab combination. Thereafter, patient usually underwent local options like surgery and radiation. If there is a PATS CR, we can give trastuzumab, or we can also combine with pertuzumab, provided initially the disease was node positive. And if there is a residual invasive disease, as we know, we use TDM1 up to 14 cycle because it has 11% improvement in disease-free survival. Next slide. So the process of receiving IV therapy is a significant burden on the entire life of HER2 positive breast cancer. because there's a logistic and time burden, because we are giving per2 and trastuzumab both. So we have to give infusion of almost 1.5 to 2 hours, and then we have to use IV access. So there's a physical pain and discomfort of infusion administration. Next slide. The nature of burden faced by patient on IV treatment differs depending on what is the stage at which they are in their infusion journey, whether it is an early disease or a metastatic disease, and what is the time since diagnosis, their own life circumstances, their working status, and the amount of time which is spent in daycare, and what all support is available to them in terms of finances. Next slide. So the length of appointment days and pre-planning requirements are major logistic burden to IV infusion. So IV infusions could be lengthy, especially when we are giving two IV targeted therapy. Next slide. So these logistic reasons actually create anxiety, frustration in patients. Next slide. Next slide. So, in studies done to assess the impact of depression and anxiety on survival, as we know that these are associated with cancer recurrence, all cause mortality, as well as the motivation to receive and complete entire treatment. Next slide. So IV infusion of Perjepta Herceptin is well established, but there are certain challenges which we have already discussed, either in terms of long infusion or in terms of preparation time or in terms of indwelling venous access, causing discomfort, cost, risk of infection, thrombosis. Next slide. So Phesgo is the first formulation which combines two monoclonal antibody, pertuzumab and trastuzumab, which is given in one vial of subcutaneous injection. So it contains the same antibodies, which is combining IV, Perjeta and Herceptin, but the route of administration is different, and it is formulated with recombinant human hyaluronidase that allows subcutaneous administration of even high drug volume up to 15 ml of loading dose, followed by 10 ml of maintenance dose, and it is a fixed dose combination. Even the timings are fixed. In first infusion it is given over 8 minutes, and subsequently it is given over 5 minutes. Next slide. So, what is the summary of Federacia and Francisca study? So, Federacia was a phase 3 randomized non-inferiority open label study where the subcutaneous administration of PER2 and Herceptin combination, that is Phesgo, was compared with the IV formulation, and it has seen that the pharmacokinetics, that is serum C trough level, which is pre-dose cycle 7, was almost same, and even the outcomes in terms of what is the efficacy, pharmacokinetic and safety, they were almost identical. And at Ferencka primary analysis, it was a study where there was a switch over from IV to subcutaneous or subcutaneous to IV, so as to see patient prefer which mode of treatment, and majority of the patients, up to 85%, actually preferred subcutaneous Phesgo over IV formulation. Next slide. So Federica demonstrated that there is a non-inferiority of cycle 7 pertuzumab serum C trough levels within Phesgo versus P plus H IV, which we have already discussed in last slide. Even the long-term follow-up data are also showing equivalent outcomes in terms of IDFS and OS. Next slide. So as we know, what are the adverse events? Even the adverse events are quite similar, except the injection site reaction, which is more in subcutaneous site. So diarrhea, as we know, diarrhea, mucositis, neutropenia, fatigue, and these are the common side effects which are quite common to both, except injection site reaction, which is more common in subcutaneous administration. Next slide. So, irrespective of the body weight, what we have seen that in this table that the adverse events were quite comparable in both the treatment arm. Next slide. Next slide. So coming to the 93% of the patient who preferred Fesgo has a very strong preference, as we have also seen in Ferencia trial that patient 85% of the patient actually preferred subcutaneous route over IV formulation because it requires less time, it is more comfortable in administration, and it is associated with less discomfort related to IV access. Next slide. So majority of HCPs felt that switching from IV formulation to subcutaneous injection actually save time and resources which are required during drug preparation and treatment. Next slide. So 66% of the patient feel restricted while receiving IV treatment versus 27 while receiving Fesgo at the primary analysis. Next slide. So, assessment of cost effectiveness of HER2 targeted treatment in neoadjuvant setting. So, it is a neoadjuvant targeted therapy which is IV versus subcutaneous, and adjuvant targeted therapy if PAT-CR is achieved. Adjuvant targeted therapy TDM1 in case of residual disease. Use of branded or biosimilar. Next slide. So what we can see that the cost of IV and subcutaneous, they were comparable, rather the subcutaneous administration was more cost effective. Next slide. So neoadjuvant treatment with fixed dose combination, as we know, is the standard modality of treatment in HER2 positive breast cancer, especially in patients whose tumor size is more than 2 centimeter or it is node positive in the neoadjuvant setting, followed by continuation of the same in adjuvant setting, or if there is a residual disease, then transition to TDM1. It is a cost effective strategy for patients who are at high risk HER2 positive early breast cancer. Adjuvant continuation of fixed dose combination dominates all the strategies that do not contain pertuzumab, as well as strategies in which IV pertuzumab therapy is continued. While it is costlier than strategies in which IV pertuzumab is discontinued, these additional costs are generally low relative to clinical benefits. Next slide. So free from lines, and so this subcutaneous combination of dual HER2 blockage is actually quite accessible. It is saving time. Now it is pain free, free from discomfort, and the tolerability, safety, efficacy, pharmacokinetic all has been very well tested, and we have also seen that it has showing good result in terms of patient satisfaction, in terms of amount of time which is spent in daycare, also in terms of the discomfort from the IV infusion. Next slide. Next slide.
I'm over. Slides are over.
Okay, thank you.
Okay. Thank you, Dr. Pooja, for such a lucid presentation, which have clearly delineated the role of subcutaneous trastuzumab plus pertuzumab therapy, which is quite easy and it is quite time effective as well as cost effective for patients. So next, I would like to call Dr. Kaushik, who is senior medical oncologist at INHS Ashwini. He'll be speaking on optimizing the treatment outcome in advanced urothelial malignancy. Dr. Kaushik, please.
Thank you, sir. Hope my screen is visible, sir.
Yes, yes, yes.
Good evening, everyone, and At the outset, I would like to thank Dr. Dubey sir and General Kapoor sir for giving this opportunity. So my talk today would be on the evolution of the treatment of metastatic urothelial carcinoma. So over the next 20 minutes, we'll go on see how the treatments have evolved and what is the present standard of care. So, starting with the data, what we have uh, in India, still we rank in around sixth highest incidence contributor across the world. We rank in the sixth in number in India, the incidence of urinary bladder cancer. And in India at present, we have it's around 17th leading causes of cancer in India and 21st leading cause in the mortality rate. So quite a few number of cases we have in India, and majority of presentations what we see in India are usually locally advanced or metastatic. You can see the pie charts on the right side, where maximum locally advanced is to the tune of 35% presentation, and metastatic is to the tune of 17%, compared to the Western countries, where usually the distant mets presentation is approximately 5 to 8%. So how does it matter? We know that once it's a locally advanced or metastatic disease, the outcome is poor. We know the 5 year survival rate overall is around less than 8%, and when it is distant metastasis, the 5 year survival is just to the tune of 7%. Also, again, disheartening is majority of the locally advanced who undergo cystectomy have a metastatic relapse, and to the tune of approximately 50% has this relapse, and those who have relapsed, they relapse with a distant metastasis with poor 5 year survival rate. So uh, we all know the major backbone of the treatment of metastatic urothelial carcinoma is the platinum agent. So majorly it's cisplatin, carboplatin. So there was a set of criteria which has been developed to see whether who fits to the patient who can be treated with cisplatin. So there's a Gatsby criteria which has come up in 2011 to see who are eligible or who are a set of findings who makes cisplatin ineligible. Basically, the patients who have echo PS more than two or more than two, creatinine clearance less than 60, or peripheral neuropathy grade 2 severity, or NYHA class 3 or more, or hearing loss of again grade 2 or more. These are cisplatin ineligible patients. For them, we have an option of carboplatin. But still, if again the performance status is worse than 3, or the creatinine clearance is less than 30, again peripheral neuropathy or a heart failure more than 3 grades, or a combination of these two makes them ineligible for any platinum agent, the platinum or the carboplatin. These are considered as a platinum ineligible. So it's important to note this prior to going on to the further approaches. So good thing, majority of the patients in our setup are platinum eligible, or we can see the tune of 60 to 70% are cisplatin eligible, and remaining around 30 to 50% are cisplatin ineligible. But anyhow, out of those, around 75% are carboplatin eligible. So important are one is performance status, as we alluded, renal functions, neuropathy, and age. What's why the major emphasis on giving the platinum or making the patient eligible for platinum is, we know, being a very chemosensitive tumor, urothelial carcinoma, the platinum agents results in a very quick responses. The responses are to the tune of 65 to 80%. You can see the multiple trials where either of the agent, either the platinum or carboplatin in combination with a gemcitabine or a dose as MVAC, we have seen the responses to the tune of 65 to 80%. And even the maximum response or duration of responses are with less than 6 cycles. We get all these beautiful response with the platinum agent. That's the importance of platinum agent. But again, the problem with the platinum agents are, though the initial response rates are high to the tune of 75 to 80%, these responses are not long lasting. So the first line chemotherapy, platinum combination, good response rate. But the problem is, once the chemotherapy or 4 to 6 cycles are over, the PFS, what majorly we get is around 6 to 8 months, and overall survival, the median overall survival is to the tune of 13 to 15 months. So then these patients usually have a relapse or a metastatic again, progression of the disease. It needs to be started on second line therapy. So over the last few decades, there was a bit of silence in the urothelial carcinoma previous decade back, where only the major platinum agents with combination with the chemotherapy regimen, whether it's a gemcitabine-based regimens or a MVAC dose, MVAC, either it can be dose or the standard dose regimen. And over the last 1 decade, there is a lot of immunotherapy molecules coming into the picture, started with that, so Pembro, Nivo, and even the antibody drug conjugate, enfortumab vedotin, has been rolled. So overall, we'll see what are the evidence for all these newer agents in the pipeline. This is the present NCCN guidelines for all those cisplatin eligible. We have a GEMSIS combination, chemotherapy followed by available maintenance, or dose-dense followed by available major regimens, chemo regimens are GEMSIS or dose-dense. Else we have GEMSIS along with nivolumab followed with no maintenance of IO pembrolizumab with enfortumab vedotin. So we'll see what are the evidences we have. So overall, the approaches can be divided into three approaches in urothelial carcinoma. One, wait and watch policy, where first line chemotherapy, a platinum agent is given, and then initiate the second line only when there is a disease progression. This is the wait and watch policy. Next approach is switch maintenance. Initiate the patient on chemotherapy, the platinum backbone chemotherapy, and after that, once they have completed the fixed duration of the chemotherapy regimen, switch them to IO maintenance, basically avelumab we have the data. And then once the disease progresses after the IO maintenance, then I can initiate on the second line therapy. So this approach is known as a switch maintenance approach. And last approach what we have is a continuation maintenance, where immunotherapy is incorporated with the chemotherapy background, and then after the fixed duration of the chemotherapy cycle, immunotherapy is continued, and once again there is a progression, we initiate them on the second line therapy. So we'll go one by one and see what the approach is. The first approach is wait and watch, where initially the chemotherapy regimen, and once we have a disease progression with the treatment-free interval, then we initiate them on the second line. Majorly, it is the immunotherapy since we have not introduced. So data here we have is a Keynote 045 trial, which showed the 5-year overall survival compared to the chemotherapy. The incorporation of the second line immunotherapy here is from 7 months to 10.1 months. So median overall survival, if you take the overall survival overall based on the first line chemotherapy and after starting the second line immunotherapy pembrolizumab, once the disease progression, overall the median survival achieved is to the tune of 16 months. So doesn't much add to the survival benefit of these patients in these approaches. We'll go on with the next approaches. What we have and the major talk for the today is the switch maintenance. Here we give a first line chemotherapy, a fixed duration cycle platinum based agent, and then once they complete the switch, either we have a complete response or the partial response or the stable disease, we switch them for the IO maintenance. And once there is a disease progression, we initiate on the second line therapy. So the rationale where it's based on this rationale is, we know that the chemotherapy helps in decreases the tumor burden, also increases the immunogenicity of the tumor microenvironment. And the immunotherapy, particularly the avelumab, also results in tumor burden. And since urothelial carcinoma has a high mutational burden, the activity of the immunotherapy is enhanced because of initial exposure of the chemotherapy. So this was the phase 3 data, Javelin Bader 100 JB100. It was an open label study where upfront unresectable or the metastatic urothelial carcinoma, there is a standard chemotherapy, first line chemotherapy. The majorly it is a platinum agent, either cisplatin in combination with gemcitabine or carboplatin in combination of gemcitabine who are cisplatin eligible. The cycles were either up to 4 to 6 cycles max. And once they have a response, either it's a complete response, partial response, or the stable disease, with a TFI of around 4 to 10 weeks, they are switch maintained. They're taken up for avelumab maintenance. Standard dose of 10 milligram per kg, 2 weekly. The comparator arm here was a bed supportive care. The primary endpoint was overall survival. And this was the result seen. The median overall survival, it improved from 20 months to 29.7 months, those with maintenance available arm. So approximately reaching it to the tune of 30 months. So overall, the delta was 9.2 months improvement in the median overall survival for those patients who had a available maintenance. Also, the PFS, there was an improvement in PFS too. It was 2.1 in the best supportive arm. It improved to 5.5 months, almost doubling up of the PFS. We can see in the 3-month data, the 5% versus 50% of the patients still ongoing with the progression in the available maintenance arm. What about our per se, our ethnic or the Asian subgroup representation in this JB trial? Here, Asian subgroup approximately around 147 to 150 patients was there in this Asian subgroup. And even these patients, when the subgroup was analyzed based on the ethnicity, even these patients fared the same based on the standard, the result what we got in JB100. Even the Asian patients had a median overall survival of around 28.7 months, and the PFS also approximately almost 2 to 3 times the higher PFS, 1.9 versus 5.6 months PFS in the Asian subgroup also. So overall, the results were comparable. So what is the patient? Also, it's important to know how much chemotherapy cycles are sufficient, whether it's 4 cycles or whether it's 6 cycles. So, what's the some the statistical analysis has been done in the study, which shows that after 2 to 4 cycles, the responses start getting after the 2 cycles of chemotherapy, and by 4 cycles, major benefit of the chemotherapy has been achieved. So there was no point in either continuing more than 6 cycles, definitely no, because you're just giving them the additional toxicity. So overall, we can stop them if someone is not that tolerating. 4 cycles, the benefit is achieved and they have a good response. And the data also shows that you can see the Kaplan-Meier over here. Those received 4 cycles and those received 6 cycles. 4 cycles, again, the overall survival is to the tune of 19.9 months, improved from 13 months to 19.9 months, and those received 6 cycles of chemotherapy. Again, overall survival improved from 14 months to 24 months. So, some patients who are not able to tolerate full dose of 6 cycles, for them, even the 4 cycles of chemotherapy followed with the available maintenance did better with the improvement in the median overall survival. Again, coming to the platinum agent, okay, then again there is a question arises which platinum agent, okay, if someone is not able to cisplatin eligible, ineligible, then how next? So again, the subgroup analysis over here has showed that with cisplatin, the median overall survival is achieved was around 31 months, but those who are cisplatin ineligible or only papoplatin eligible, even that they fared better with the median overall survival of 25 months. So even either of the platinum agent, irrespective of the first line chemotherapy backbone, you have a good median overall survival benefit. So, and again, the response rate, whether only complete response patient do better or only the stable disease or which response is good. Again, OS and PFS benefit is seen in these. You can see the Kaplan-Meier. There is a separation of the Kaplan-Meier in all this. So, definitely much better in the complete response, but even the partial response of the stable disease patient also fared better compared to the best supportive arm. The benefit was seen in both OS and PFS. So how long it's important to continue maintenance? So what is the maximum in the trial? What we have been seeing is majorly around 47% of the patients were exposed to more than 6 months, and in that around 28% were exposed to more than 12 months. And those who had exposed to more than 12 months, the PFS was seen to the tune of 26 months. So patients who had maintenance of more than 12 months and median overall survival was not. So if we are able to give more than 12 months of available maintenance, the impressive results have been seen in this analysis at all. Safety profile, yes, definitely when compared to the best supportive case, there will be toxicities, but major of the toxicities are quite tolerable. The grade 3 toxicities were less up to 5% only. And presently, we know we are all well versed with managing immunotherapy toxicity, so it's quite manageable and can be seen. There are some issues which are seen that immunotherapy related pulmonary toxicities. But what's seen that those toxicities were actually in the lower side when with the use of avelumab compared to the other immunotherapy agents, be it nivolumab causing pneumonitis to the tune of 10.5 in the odds ratio, or pembrolizumab causing some of the pleural events. So overall, avelumab was well tolerated. Efficacy wise, and coming to the real world data, there after this JB100, again there is a lot of real world data coming up. So these were the events and the ready data. Again, same, the median PFS was reflected from the JB100. The median PFS and the OS benefit was almost achieved in the same real world heterogeneous population too. So this was the latest update of the Evans study where they had tried after giving the platinum initial chemotherapy and switch maintenance to avelumab. Those who had progress after switch maintenance, they have exposed to antibiotic conjugate, the enfortumab vedotin in the second line. The median overall survival was 40.8 months of the overall survival. So this was the background of this Evans study. It was the largest real world study which shows that after the patients exposed to second line treatment, how what is the benefit of response. Here, the overall survival what achieved was 40.8 months for those patients on progression of development maintenance and exposure to enfortumab vedotin in the second line. The last approach, if you come to the last approach, was a continuation maintenance where chemotherapy backbone, again, immunotherapy was added initially, and later on, after the fixed duration, we continue the immunotherapy molecule. And once they progress, then we start on the second line therapy. But here, Atezolizumab was tried with platinum and gemcitabine combination. Keynote 361 tried pembrolizumab, but both of the studies were the negative trials. They did not meet the significant difference of the OS was negative. So these were the negative trials. Only the checkmate 901 fared better, where nivolumab in combination with the GEMS was a positive trial, but the OS gain were just marginal. Around 2.8 months of the OS gain was seen with checkmate trial. Basically, this is the checkmate 901 full study design where first initially they divided the patients into cisplatin eligible and ineligible, and they had a four-arm study basically. The arm either with the nivolumab in combination with the chemotherapy or nivo and IO combination or only chemo as a comparator and best supportive as a comparator. But however, the Nivo and IO arm was a negative arm the initial upside, and then the BMS had to withdraw the approval for that initial Nivo and IO. Followed by that, they reduced the arms and only they maintained the single two arms nivolumab in combination with the chemotherapy. Only cisplatin. Important is only cisplatin eligible patients were included after. So nivolumab with gemcitabine and cisplatin or gems is as a combination, followed by nivolumab maintenance in those arms. You see, we can see the outcome over here compared to the GEMS as a comparator arm. Those who had exposure to nivolumab, the median PFS gain was hardly 3 months, hardly less than 7.6 months to 7.9 months. Just additional 9 days of PFS gain in these patients. And coming to overall survival, so median overall survival, the gain was just 2.8 months gain compared to the only chemotherapy back. So but interesting was, so I though the atezolizumab was a negative study over here, the gain was almost same what we have achieved with the IM figure 130. So OS benefit of so same thing when we atezo was involved with combined with the chemotherapy. The same benefit was achieved with the nivolumab with the chemotherapy. So whether we didn't find any impressive result to go on with this approach. Also, the toxicity is definitely there when we combine immunotherapy. There is some certain of toxicities compared to only chemotherapy background. So when we compare this arm with the Bavencio group, we can see though in the Bavencio what happened, all the platinum eligible patients were included, but in the nivolumab arm only cisplatin eligible patients were included. So the total eligible patients were approximately less than 50 or less than 50%. And we don't have much of the data on the Indian patients or the Asian subset in the nivolumab. So, and the comparator arm in the Bevin show, the comparator arm also better supporting care compared to the maintenance arm. But on they were exposed on progression. Approximately 75% of the patients in the best supportive group had the exposure for immunotherapy. However, in the nivolumab, Gemcis, once they had the progression, the comparator arm, the available maintenance was restored only in the 9% of the patients. Basically, the subsequent therapy also was reduced in this arm. So we can just see so the PFS benefit Javelin giving approximately 3.7 months improvement in the PFS here only 9 days improvement in the PFS. The median overall survival 31 months, nivolumab with gemset combination is only 21 months. So overall, when we see the response is sustained and the longest overall survival is achieved by the available maintenance. The median overall survival 31 months compared to other approaches which we had discussed now. So also there was a lot of innovations coming up to maximize the OS benefit and so that how can the initial IO combination can be whether there is IO combination. No, it was a negative. Durvalumab was tremelimumab was trained in the Danube trial, did not meet standpoints and negative trial. TKI was trained. The LEAP had a arm of a pembrolizumab and dinumotinib. Again, they did not meet the endpoints and it was a negative trial. And later there was a immunotherapy and the antibody drug conjugate enfortumab vedotin which met the PFS and OS endpoint, and finally it was a positive trial. This was the EV302 trial design where the previously untreated patients managed to on randomization to enfortumab vedotin and pembrolizumab combination, and the comparator arm was the standard chemotherapy regimen. The endpoint was PFS and OS. So overall survival, yes, impressive. 31 months median overall survival compared to 16 months in the chemotherapy arm. But issue was with the toxicity. The enfortumab vedotin has its own particular set of toxicities, high risk of hyperglycemia, skin reactions, peripheral neuropathies, eye issues. So the grade 3 events were currently on a very higher side when comparatively, and we don't know much with the usage of these whether these are reversible or absolutely irreversible toxicities. So impacting the quality of life of these patients. So, and also important was the sequential treatment what the patient received. So, seen was only 30% in the controller arm when compared to the EV versus EV with pembrolizumab, they had received the available maintenance. So, subsequent treatment was not that balanced in these patients in this trial per se basically. So if put on the Evans study design in those with JB100 patient progressing after available maintenance, if the enfortumab vedotin was used in second line setting, overall median overall survival was 40.8 months compared to all other set of patients with has been seen. Overall, the treatment algorithm have been made based on all these data available. First, we decide whether the patient is platinum eligible, and then whether the fit is cisplatin or carboplatin eligible, and then start on therapy with the chemotherapy background. And once they have a response, either it's a complete response, partial response, or stable disease, start on the available maintenance. And once they have a progressive disease, start on the second line therapy. Those with platinum eligible, we have option of directly going with the pembrolizumab drug. So importance in the JB arm was the best supportive arm, which received the subsequent group. We almost seen that in the Javelin trial, the best supportive arm, around 75% had this patient received the subsequent therapy, either with the immunotherapy. So overall, these were the subsequent therapies which have been shown. We can see the majority of the patient was received the subsequent therapy. Either a few of them were rechallenged with platinum agents, or either it can be other single agent chemotherapy. So just to summarize, we know that platinum-based combination chemotherapy is the standard of care in the platinum-eligible patients, metastatic colorectal cancer, and the median overall of impressive of 40.8 months reported in available maintenance followed by second-line enfortumab in patient, impressive median overall survival. So based on this, the category 1 recommendation is present, and also important is the efficacy seen was irrespective of the first-line chemotherapy, whether it's cisplatin or the carboplatin background, irrespective of the responses, tumor PD-L1 status, and also on the based on the duration of the chemotherapy and interval of the therapy. That is important. So, and also we have the real world data, which is substantiating this. So, just 2 or 3 more slides of a patient with a typical case and our approaches based on all this data we have. So, we had a 83-year-old male patient diagnosed urinary bladder, apparent underwent URBT and had a depositioning done, nil comorbidities. Ultrasound had a polypoidal growth of around 3 to 3.5 centimeter involving the circulatory junction. Histopathology revealed a high-grade invasive urothelial carcinoma. The stage as a stage 3A disease and was planned for neoadjuvant therapy into 4 cycles followed by radical cystoprostatectomy. First cycle was started with gemcitabine and carboplatin, and then with the good tolerance, he was then because of the age, then he was taken up for cisplatin. Overall, total 4 cycles were completed with a good response, and after that, however, because the response was so good, the patient was lost follow-up for more than 1 year. After a year, he again presents with hematuria and back pain. On evaluation, it was a metastatized disease for both the skeletal mets, the lymph nodes, and the sternum. So then again, since there was long duration, he was planned to rechallenge with the platinum doublet, gemcitabine with the platinum combination. With the interim PET, but again the response was good. Based on the approach, we thought of maintaining on the switch maintenance therapy. He was started on available maintenance. So after the initial response with chemotherapy, 6 months post available, there is a very good response. The PET showed there is a regression of therapy. After 1 year, again reassessment, the response was ongoing. So he continued approximately more than 2 years of available with this ongoing response. So this is one of the stories what we can see, and some of the patients will do better with this switch maintenance therapy. And even those progresses, we have this option of exposure to EV, and so that we can get this impressive overall survival benefit. So thank you. With this, I close the session. Thank you.
Thank you, Kaushik. Such a perspicuous presentation. So, what's your experience in clinical practice for avelumab?
Sir, we have few patients. Sir. We have started them on the maintenance, and they're doing well. They're tolerating well.
Both in urinary bladder.
Urinary bladder. Sir.
Okay, thank you. So, with this, I would like to thank each and every speaker as well as attendees for sparing their time for attending this CME and making it a successful academic feast. Over to the technical team.
Thank you, sir.
Thank you everyone for joining us. Good night. Technical team, please close the meeting.